Picture this. The journey ahead starts here together, and together we can build a brighter future. You are listening to Illuminating Hope, a podcast of Hope House. Dr. Bridget McCandless is passionate about her community. She started her career serving medically under-resourced families living in eastern Jackson County. As an internist, her career and volunteer efforts focused on providing high-quality, evidence-based, culturally competent care to adults without insurance. Earning her MBA allowed her to expand efforts to affect durable public policy change at local and state levels. She is fortunate to have been part of the Health Forward Foundation in its early years and later as CEO to use public funds and advocacy to strengthen communities in the greater metropolitan Kansas City area. She now turns her efforts as an at-large city council member to support the great city of Independence. She truly believes in the vision of Independence to remain a vibrant, historic, full-service community that celebrates its unique multicultural heritage and respects the environment while fostering a stable, diverse economy. Dr. McCandless, welcome to the Illuminating Hope podcast. Glad you're here.
Thank you for having me. I'm delighted.
Today I want to talk a little bit about domestic violence and the history of health concerns behind domestic violence and how domestic violence survivors are treated a little bit different in the medical realm. Can you talk a little bit about the history of that?
When you think about domestic violence, we got almost no training in medical school to approach domestic violence victims, how to screen them, how to refer them, how to think differently about their injuries, both the ones that you can see and the ones that you don't. I know that there have been improvements since I was in medical school. I guess I'm really dating myself. So the answer to that is I am really old. And things are getting better. But if that is not a part of your worldview, it takes some real work to make that an appropriate screening list that's running in the back of your head when you see someone for any kind of injury.
You know, it's interesting. I just went to the doctor this morning, and the nurse was taking my blood pressure and doing all that before the doctor came in. She asked me this list of questions, but it was so interesting because I know that those questions were never asked early on, but it also has to be about the way that you ask those questions too, because I knew what she was trying to get at, but she was so mechanical, and so I just need to check this box that I wondered if I had been experiencing anything, how would I have felt to answer those questions differently? Because I don't know that I would have been perceived. It was interesting because I think we have come a long way, but I still think we have a long way to go as well.
I was at the doctor this morning too and got the same question. And in my head, I'm like, okay, you have your back to me. You're looking at the computer. You're not giving any eye contact. You are sending me the message of, I have got to get through this checklist. For God's sake, don't say yes.
Right.
It's interesting because I went to the doctor with my dad a couple of years ago and the same thing happened and she asked about falls. And my father said, no, I'm sitting next to him. My eyes are huge, but she can't see me because she's at her computer. And so sometimes I think we do these things to make us feel better, but they aren't actually effective. When I was in practice, my question was, does anyone hit you or hurt you or make you feel unsafe? And that's broad enough that that could be at work, that could be my next door neighbor, that could be someone in my household, but it was always, I'm looking at you so that I can read all the things you don't say with your mouth, but you say with your body.
Right.
Unfortunately, I'm not sure our screening tools are that great.
I don't think we're teaching that either. One of the things that we've been able to do is partner with the hospitals and really work on that, just trying to improve those systems. But the hospital is just one piece of the healthcare system. I wasn't at the hospital today. I was at my primary care physician's. So to try to reach all of those people and to really make those connections. But I think you're absolutely right that it was like, she wasn't interested in me answering that in any way. I had a never, not often kind of a scale. And if I would have said anything other than never, I'm not sure. I don't know what she would have done. I just want to get through my checklist because I have to go see the next person that's waiting in line.
What do you think that income, education, socioeconomic status this in different communities, but what do you think the effects are on that in the healthcare realm when a domestic violence survivor is trying to come to seek medical attention?
Back to physicians and providers are time pressed, so we give that aura off when we walk in the room that we've got 8 minutes, and so I'm going to sit your head up and I'm not necessarily going to ask too much. And when you add those other complexities, social complexities, whatever those are, living situation, language skill, ability to read, ability to advocate for yourself, presence of a child in the room, all of those complexities alter whether the provider knows it or admits it or not. It changes the dynamic in that room. Unless you have both the training and the sensitivity to be aware of the many manifestations of intimate partner violence, you may not pick up on what that woman is trying to get from you, and she may also not be willing. You're going to have to ask much more probing questions like, this injury doesn't make sense for how deep it is, how severe it is. You said you bumped your head on a cabinet, and yet I'm pulling debris out of your scalp, or you have a set of bruises in various stages that make no sense for I bumped into the wall. You can't get I bumped into the wall with 3 weeks of versions of bruises. And then the other is just the things that don't make sense. You come in for pelvic pain or you come in for abdominal pain, but I can't find anything on exams, and your labs are normal, and something just doesn't jive. The physician goes to, this person's making it up or they're malingering, and just because you can't see it doesn't mean it isn't real. And just because it isn't physical doesn't make the pain less real. Our ability to cope with, address pain that doesn't fit in a neat box, we do a pretty crummy job of that.
When you were at the free health clinic, I know it had different names, you were in charge, but yet you saw patients. And I know that just from our conversations that you spent time with your patients and you really got to know them and you really took their health very, very seriously. What did you do to have people trust you, confide in you, and help you to be overseeing all of their health care?
A couple of things. We rotated as a team. So when you saw me as your doctor, you saw the same nurse, the same pharmacist, the same lab tech. That way, that consistency, both in what I expected of my teammates, what they expected of me, but also the patients. You may be willing to tell the nurse what you're not willing to tell the doctor. You may be willing to tell the lab tech what you're not willing to tell the front desk person. And so that small team made a big difference. The other was, as any physician knows, the best doctor's visit begins at the front desk. If that person adores you, goes out of their way to make whatever modifications you need, greets you by name like they're glad to see you, even if you have a wait, but you know that they're paying attention to you, you haven't been forgotten, they give you an update, Dr. McCandless is running behind, she's going to be here in 10 minutes. All of those things create kind of that personal approach to medical care. And I'll admit, I was completely spoiled. I didn't have to bill. So I was not chained to my list of diagnoses. If it took me longer, it took me longer. Because I had to create a lot more magic because we didn't have any insurance, it meant that I used exams, special testing much more judiciously. That meant lots of TLC on the front end, a lot of listening, a lot of history taking. You could come back and see me in a week. If I'm like, I'm just not sure what's wrong with you, you need to come back fast. And really good physical exam skills. People will tell you many, many things when they're being examined. There is just sort of a communion of relationship in that touching. I think touch is healing all by itself. Even a good exam is a healing experience. Someone's like, oh, this person is taking me seriously. They are looking at all the things I'm worried about that I'm not able to say out loud. So because of that, it was heavy on the relationship, much lighter on the CAT scans. And so our patients did much better.
Everything you just described goes back to a survivor, like we've been talking. Lack of trust, the fear that someone has when they go to the doctor that it might be found out and then they're going to get in trouble because they said too much. But you encountered survivors during that. Did you have to do anything, or how did you as a physician make sure that that individual stayed safe?
I always started with, this conversation is between us. It's not between me and the lab guy. It isn't between me and the front desk person. I had a lot of folks who would be like, I want you to take pictures, but I don't want you to put them in my medical record. I'm like, okay. So I would do that, and I would put them in a special file that I kept locked in my desk drawer. Nobody else saw that. And what I would say is, if you reach the point where you need this information, I have it. It's still been custodial, meaning I've kept track of it, and then we can use that in a court of law. There were people who would report sexual assaults but never wanted it written down in case for some reason their partner got a hold of their medical record, and I would write confidential matters discussed, and then that would be in a separate place. Those were small things, but I think it allowed them to feel as though they were in control, which is a huge piece when they have so little control over so many things. There were other folks who weren't ready, and I would say, I know something else is going on here. You can't talk about it today, I can tell, but I'm going to be here the next time you come and the next time you come, and when you're ready, you can talk to me about that. I also gave them the option of emailing me or phoning and leaving me a message if they couldn't talk to me personally because it was too intense. So just trying to find mechanisms that allowed them to share their worries and concerns in a way that worked for them.
Was there ever a time where you knew that abuser came in with the survivor in your clinic?
Oh, yes. And so you have to create a whole bucket full of creative ways that get the abuser out of the room and protect the safety of the client, because she may or may not be ready to tell you. We had a whole set of things, like our policy is that if anybody is undressed, there can only be one person in the room. Could you just step in the hallway? You can really make up all the policies you need to on the moment.
Well, you're the physician, of course you can.
Yeah, to get folks out. We always ask people to take this survey for us, and so I'm going to call my front desk person and see if you'll sit outside and fill out this survey to help us out while I talk to her. Creating a number of ways, or finish the exam and meet her in the bathroom. I mean, there are ways. Boy, your radar has to be up. Mm-hmm. And sometimes it isn't the first time you see them. It's usually the second or third. You're like, wow, this guy answers all of her questions. And you have to put an end to that on the spot and be like, you are not my patient. I really want to hear from you at the end because what you have to say is really important, but right now I need to hear from her. The last thing I want to do is put her in more danger. You have to thread that needle.
That's the challenge right there for a physician, nurse practitioner, whoever's seeing the survivor, because if you don't have the time, the patience, and the knowledge, then all of those things are going to be skipped and missed, and then she or he are going to be left without the resources that they need. I think that continues to be our challenge, is to be able to make sure we're educating and making sure people have that information.
Well, a lot of physicians will tell you, I don't want to screen because I don't know what to do with the answer. It doesn't matter because it's not your job. You have a million other resources to hand this person off to, but you're the person who has to ask the question because you're in the room.
Somebody has to be that conduit for the survivor.
And I do think that's where we can meet those providers and give them the information, make sure they know that we are here as a resource. We can be of assistance in that.
If there was more training for physicians in medical schools, what do you think would have been helpful?
I think actually a dedicated lecture just on domestic violence, because thinking about physicians are very visual learners. Okay, look at this. Okay, why would I have looked at that head injury and said, that doesn't make sense? Why would I have listened to this story and said, that doesn't make sense? But also to acknowledge your most frustrating patient, you need to keep this in the back of your mind because their story doesn't make sense. The person who makes you furious, I always come back to two questions. Do they have a mental health issue? And that's why I'm so mad by the end of the visit, because they aren't following any of the normal patterns. Or are they someone extremely vulnerable that I need to step back and ask different questions? It was one of my wonderful professors who said, the person you least want to see when you see them on your schedule and you're like, oh, this is so-and-so. That's the person you need to spend the most time with, not the least time with. And he was just a gifted clinician, and I took that to heart.
When you were running the free clinic, did you ever, in your line of questioning, talk about past trauma and how that affected the body today? And can you speak to that a little bit?
You know, I do some lectures on trauma, and I tell folks this is the next germ theory. Germ theory, for a long time we thought it was bad humor. tumors or bad water, or you'd been cursed or something else, and that's why you had a disease. We come to figure out, there are those microbes, and they spread, and they sometimes spread through vectors like rats or bad, contaminated water with sewage, etc. Trauma is the next germ theory. We know that traumatic effects have cumulative effects on the brain, on the body, on the psyche, and I can't medicine my way out of that without both acknowledging it and saying, this thing happened to you and it has real consequences for you. But people get better, and we have tools and we have mechanisms. And can I take away the fact that you need a knee replacement? No, but I can help your muscles be stronger so that when you get your knee replacement, it works. Same thing with patients who come in and they've had traumatic head injuries. Something we don't talk nearly enough about in domestic violence is that those things are additive. We talk about it all the time with kids getting a concussion on the basketball court or on the football field, but we never talk about that in women who've had sequential head injuries. And the thing is, they don't all have to be horrible, but they add up and they contribute to depression, to anxiety, to changes in their executive function, so their ability to follow through on getting out of a domestic violence situation is complicated. And if your executive function isn't good, meaning can I sequence, can I make a list, can I figure out how to hide a little bit of money every month, can I figure out who can keep an extra set of keys, who's going to come pick me up at 2 a.m. when my husband's locked me naked on the front lawn. But the other is that we know that those cumulative brain injuries increase the risk of dementia. This growing population of people with Alzheimer's and dementia may have had those beginning findings in physical trauma, but the emotional trauma and the psychological trauma flows through in every aspect of well-being. Your ability to sleep, how much weight you gain, whether you have an increased risk of diabetes. There's also the traumas around sexual health, increased risk of miscarriages, complications with pregnancy, infections, urinary tract infections. A lot of that goes along with the sexual trauma that comes in certain relationships. So it is complicated from top to bottom.
Since we're talking about health disparities, I definitely want to talk about how hard it is when you do need psychological or mental health, how many visits you need to go to, how expensive it can be, and how a lot of our population, you would know, having a free clinic, a lot of our population do not have health insurance. What do you think the answer is?
That is a loaded policy question right there. Let me start with 988, and I only start there because I want everybody on earth to know about 988. So 988 is a way to call and get somebody who will talk to you on the phone, and they will support you in the moment. They will screen you for suicidal ideation. They will help you get connected to resources. If they think you are in imminent harm, that you are actively working on suicide at the moment, they will dispatch police. That's the spectrum of 988. But it's also text or call because people are comfortable in different realms. We have Spanish access. If you LGBT, we have a special line for them. So 988 is a gift that America gave itself. It is being used probably more than anybody realized, and that's only with 25% of the population even knowing it exists. Right. So let me start with that as a good thing. When it comes to getting therapy, different people need different versions of therapy. I will tell you there are not enough therapists in general, but there are an increasing number of technologic apps that will let you get started at least. There are ways to connect to providers who may not be in your neighborhood. Maybe it's really important to you that you aren't using a provider anywhere near your house. We've found in rural communities, everybody knows everybody's car. Nobody would go to the mental health provider until they started doing online or telehealth. And then lots of people got care because nobody had to know. And then there is such a shortage of Black and brown providers because we know that congruency, meaning the race of the person and the race of the provider, you get better care when those two things match up. And there just aren't enough, especially for kids. So I know that's an area that lots of schools are looking at, how to bring more providers of color into the fold, but they get busy really fast, and that's one of our great shortages.
Do you think it's society that will we'll ever see a day where mental health is treated as wellness.
I think it's getting much better. My kids, the way they talk about mental health is dramatically different than my generation, and like scad's different than my dad's generation, where your job was to shut up and bear it no matter what. And so my kids are much more open with how they feel about how people make them feel, what friends are good for them, what situations are good for them, and really kind of think about their own preventive mental health, which has never been a thing, right? Everybody was just like, well, it's not until your screws are loose till you go to see the shrink, right? And now people are like, hey, my brain's part of my body, my emotions are part of my body. I know that if I treat them well and care for them, they will care for me back. I just think that is better.
When do you think insurance companies will see the benefits of mental health coverage?
Legally, you are required to have mental health parity, meaning that if I cover physical health, I must cover mental health. You can't have different sets of copays, you can't have different caps.
Oh, that's nice.
That's federal law. That is what's on the books. What is happening in reality, not so much. But you're starting to see a lot more lawsuits that are forcing insurers into having true mental health parity. I mean, there are ways you can pretend you have it by having a network of all providers who aren't accepting patients, then I never have to pay for it. So there are things that the federal government is doing on network adequacy, saying, okay, you've got to have real people who take real patients in order to say that you have mental health parity. That will get better over time. More and more employees are demanding it. Mm-hmm. Unions are demanding it. School districts are demanding it. And because of that, and more organizations are having EAP. So that exists. Right. You know, the Employee Assistance Program exists outside of your insurance. So I think people are getting so much more comfortable with it that it will be the expectation that that coverage is there. And the insurance companies are going to figure out that the person who gets good mental health care costs them a lot less on the physical side.
100%.
Yeah, but the actuarial work hasn't been done yet, but it is coming. There are lots of researchers looking at this.
That kind of just segues into what I wanted to ask about was, we know that domestic violence survivors suffer the trauma, and you talked a little bit about the head injuries. What are the long-term effects of untreated, just basic things like high blood pressure or diabetes? We know that domestic violence survivors do not put themselves high up on the list. So when there's things to address within the family, they're at the very bottom. Medical is one of the lowest on the tier. What are some of those impacts that people can have for not even talking about the abuse and the things that come with that, but just some of those longer term health issues?
So I think there's twofold. Stress is real. I think of it as a poison. You know, you put that toxin in your body, it's going to do something to you. So we know that all that internalized stress affects your sleep. We know sleep is deeply associated with both well-being, mental health, and risk of diabetes. But it also changes your whole cortisol system. So if you think of cortisol being one of your hormones for fight or fight, that gets ramped up. So it's just like those people are on high alert all the time. And high alert is great for a short period of time. But when you're on high alert all the time, think of just everything in your body getting squeezed. So your blood vessels, so your blood pressure goes up. The amount of sugar that your body releases instantly into your blood in case you have to run away, well, now it's releasing that sugar all the time. It affects your appetite. A lot of folks, huge weight loss or huge weight gain or lots of cycling. We know that the brain and the body are so tied together, and stress is the one common thread between the two. Obviously, there's huge physiologic changes that come with being under chronic stress, but there's also delayed care, which you were talking about. I have so much to do to stay well, protect my children, manage my partner so they don't get volatile, that there's no time to go to the doctor. And then there's also another form of abuse is refusing medical care for your partner. So they don't get taken. Your issue is it isn't real. You've made it up. You're hysterical. And you begin to believe that. You get told that enough. Well, maybe my pain isn't real. And so you get delayed care. We know delayed care is more expensive and much harder to treat. It's multifactorial. And diseases all play against each other. So when I get diabetes and high blood pressure, now I get heart disease. And I get diabetes and high blood pressure, and I get kidney disease. and all of those ratchet up my risk of cancer. So just from a pure mathematical standpoint, it's a very expensive population. By the time they reach medical care, all of the easy prevention stuff is already out of the gate.
To me, domestic violence is a medical issue, because whether we're talking about mental health or physical health, all of what you've just said, all that we've been talking about, it plays just such an important part of that person's life. But we don't think about it as a medical issue. We think about it as a societal issue or personal issue, not even really societal. It's like this between these two people, but it really isn't. I mean, it's a big concern, and if we're really going to address it in our society, we have to look at it from all of those aspects. One of the other things that I don't think gets talked about enough are the effects of strangulation. That is something that even when somebody's been strangled, they say, I've been choked, or they don't talk about, I was strangled to the point of unconsciousness, and how deadly that is, and how just the fact that you came back too. Do you have the physical effects of somebody who's been strangled either once and often what happens is multiple times?
I mean, so think about it. You're cutting off the blood supply to your brain, and your brain doesn't forgive you very easily for that. And back to, it's cumulative. So that's a form of brain injury. So that repeated strangulation, but it also causes all kinds of problems with breathing, with vocal cords. So you can fracture the hyoid bone, which is the bone right at the base of your neck there. That can be a medical emergency. There's more internet porn where strangulation and choking are becoming normalized as part of a sexual encounter, which I think may numb both the participant and the perpetrator to the severity of it because they're seeing it in other places. I don't know the outcome of all of that, but I think strangulation issues are going to become an increasing problem that we're seeing, and it's hard as heck to recognize. Unless you've got bruises, there's not a whole lot to see on the outside afterwards. I don't even know that I would know how to ask questions about that.
I know that there's been a lot of trainings that I have seen for law enforcement about how to take the evidence and the data. I went to one of the conference that I was at, and they talked about your memory's not as great, not a good reporter of what's happened to you because you don't know, you don't remember, and then some of those delayed effects of how it impacts your urinating and just even other things that you don't necessarily associate with your brain. But I don't know that we're talking about it as much with the health professionals as they are with law enforcement.
Oh, I think almost not with healthcare providers. So if you're thinking about working in the ER, that might be a topic well worth having a conversation with your providers about.
Even the language difference between choking and strangulation, they're two totally separate things, but the word choking, I think, is used more so than the verbiage of strangulation.
Law enforcement in our area participate in this lethality assessment project, and that is one of the questions they ask is, have you been strangled, or something like that. It's one of the questions. I mean, if you're going to go to that level, you are in high danger. I mean, that's a high risk, really. I mean, it's attempted murder. They're trying to cut off your airways and you're going to the point of unconsciousness. There's just been a fine line before you're not going to come back again.
Dr. McCandless, I did want to talk to you really quick before we wrap things up here. There was a dentist that you met years ago, and he has been an amazing connection for us. Mary Ann, do you want to speak to that a little bit?
I approached you to help me with setting up a clinic, a health clinic, and you came over to the campus and you looked at the room and you were very kind, which I think inside you were like, oh my God, this woman has no idea what she's talking about. And really very quickly I learned that that was way out of our scope and that we couldn't do something like that. I had hoped that we could do something on site that would address immediate needs, not realizing the scope of what I was envisioning. But you did introduce me to Dr. Ryder, because we also not only wanted a health clinic, we wanted to do a dental room, a dental clinic at the same time, because we know that health needs are low, but dental is one of the last things that a survivor will address. And he's turned out to be just a lifesaver for us, and he's grown our clinic. It's been over 10 years since he started, and he's been a lifesaver.
Well, that makes me very happy. You never know when those random connections are going to turn out to be great gifts.
And I would have to say hundreds of survivors and their children benefited from this clinic and are still benefiting from this clinic.
Right. He was the only dentist, and now we have 3, and he brings in hygienists, and he gets us the supplies, and he gets us the equipment, and he's been a lifesaver, and the ones he's bringing on have been wonderful too.
That's great.
Yeah.
You forget how important your smile is as your first communication communication tool, and as part of getting a job and establishing relationships, that smile matters. I think we sometimes underestimate how important it is and how it makes people feel when they have their beautiful smile back. So I'm so glad.
Dr. McCandless, thank you so much for coming on today, and thank you so much for everything that you've done within our community to help society as a whole.
Thank you. It's lovely to be able to come and visit with you. Hope House has a very, very special place in my heart. My dad was on that original board of directors. My first encounter with Hope House was when I was 8 years old, and we went to your very first shelter, which was a converted house that really needed a lot of love. And I remember thinking, thank God I get to leave. And that made a huge impression on me. So domestic violence has been something our family has talked about, been aware of forever. So it's my joy and privilege to get to see you guys and celebrate your great work in the community.